Okay, thank you everyone, and welcome to our 5x5 Antimicrobial Audit webinar. Just a reminder that this webinar is being recorded and will be available on our website in the coming month or two. So we'll be placing you all on mute while we work through the slides, but we'll be stopping at times throughout the presentation to give you a chance to ask questions. So in case you missed last week's webinar, the 5x5 Antimicrobial Audit is a continuous audit, intervention and feedback activity, and it captures data on two key antimicrobial prescribing indicators. They are the documented indication for antimicrobial therapy and the choice of antimicrobial therapy being consistent with guidelines or non-concordant with a documented reason. Auditors are prompted to make interventions to promote best practice prescribing, and that's essentially when either of those two indicators have not been met. It's called the 5x5 Antimicrobial Audit because it requires a collection of data on 5 questions in 5 patients for each week on a ward or a unit or within a service. The results are intended to be fed back to prescribers and other people in the unit or in your hospitals that are affected by the audit on a regular basis. And pilot testing has shown that the audit is sustainable and flexible and can usually be incorporated into a clinical healthcare professional's regular duties, taking about an hour a week to identify 5 patients, answer the 5 questions for them, make any interventions and record the results. This is the second session of a 3-session series, and for today's session we'll be concentrating on measuring guideline concordance and the other measures in the audit, and working through some challenging cases. Next week we'll do a session on making interventions and providing feedback, and you'll receive links to session 3 webinars and the phone number by email towards the end of the week. Okay, so let's recap. So if we move on to what the 5x5 Antimicrobial Audit measures, question 1 is there a clearly documented indication for antimicrobial therapy? So what this means is a rationale or a reason for prescribing antimicrobial therapy. And it needs to be provided with enough clarity and precision to be matched to a diagnosis or a diagnostic-related group in the relevant antimicrobial guidelines. And if you have a look at the questions, question 3 is about is the choice of therapy concordant with guidelines. So we actually need to make sure that we know what the reason is for antimicrobial therapy so that we can answer that third question accurately. When we say a documented indication, that means that the indication is included in the patient's notes, on their medication chart or in the electronic medical record, and there might be a few spots in your hospital where you record that. And it needs to be documented by the prescriber, so that's usually a doctor, as opposed to being written on the chart or in the notes by a nurse or pharmacist that may have figured out what it's for. The intention of this question is to see whether the person who's prescribing or initiating therapy has actually documented the reason. So if the patient's receiving antimicrobial therapy for separate and concurrent infections, all indications must be documented in order to answer yes for question 1. So say, for example, the patient's on 3 antibiotics and 2 of them are for community-acquired pneumonia, and the third one you're not quite sure what it's for. There doesn't seem to be a reason documented in the notes for what it's for. It might be an antibiotic that's usually prescribed for a urinary tract infection, but if that's not stated in the notes, then your answer to question 1 would be no. In deciding whether or not documentation is clear enough, think about whether other healthcare professionals that are in a role similar to yours would be able to answer the question based only on the information presented. So for the purposes of the audit, don't use information that you may have overheard or that may have been talked about in handover or on a ward round. This is really about what's been documented and communicated in the patient's notes. So if we look at a couple of examples, say a patient was admitted with a skin condition, and at the time that antibiotic was prescribed, they thought it might be dermatitis or it might be cellulitis, and then later in the same entry there was a plan for IV flutoxacillin. this would be considered clear documentation as an indication, because you can see that the IV ciprofloxacin has been started because we think that the patient may have cellulitis, or the prescriber thinks that. On the other hand, writing pneumonia or query chest infection would not be considered clear enough documentation, because there's lots of kinds of chest infections. There's community-acquired pneumonia, there's hospital-acquired pneumonia with or without aspiration, there's infective exacerbations of COPD. So if you need to match what's been prescribed with the guideline, you need to know what kind of chest infection exactly the antibiotics have been prescribed for. So why promote documentation of an indication? Why are we getting you to record and measure this? Well, firstly, it's good clinical practice. It serves as a bit of a double check that what's being prescribed, that the medicine that's been selected matches what it was intended to be used for. It also ensures that there's communication of the diagnosis and the reason for the patient's medicine between clinical teams that are looking after the patient, and also with the patient, their carer and their family. So if everyone's on the same page about why the patient's on an antibiotic, then it improves that communication and other things that may need to be done in relation to the therapy. It also supports review of treatment. So if you know that what a patient has been prescribed their antibiotics for, then you're more likely to be able to determine whether it's appropriate for that therapy to be stopped or to be reviewed, or if they're on intravenous antibiotics, for that to be stepped down to oral antibiotics. If you don't know what the patient's been treated for, it's harder to prompt that review. It's also been included as a recommended indicator in the National Antimicrobial Stewardship Clinical Care Standard. And if you don't know about that clinical care standard, we've got the link there. But essentially what it describes is the care that a patient should expect and should receive when they're prescribed antibiotics for an infection. So question 3 asks you to determine whether the choice of antimicrobial therapy is concordant with guidelines. And what that means is the choice of antimicrobial therapy, the actual medicines or antibiotics selected, matches what's recommended in current locally endorsed guidelines, or if these are not available in the latest version of therapeutic guidelines antibiotics. So by locally endorsed guidelines, we don't mean a scrap of paper that's passed around the ward and say, prescribe these antibiotics because this is what we do around here. It's guidelines that have been approved by the local committee in your facility that oversees antimicrobial prescribing. So this might be the Drug and Therapeutics Committee, or it might be the Antimicrobial Stewardship Committee, or in smaller facilities you might have a quality committee or a quality and safety committee that endorse these types of guidelines. If the patient has a really uncommon infection and you can't see the indication in either your locally endorsed guidelines or the therapeutic guidelines, then that patient is out of scope for the audit and you would discard the data. You would do whatever you would normally do in terms of your role in looking after that patient and their therapy and communicating with the prescriber, but they wouldn't be one of the 5 patients counted for your audit. Okay, so the 5x5 antimicrobial audit targets the choice of antimicrobial therapy as a simple and as a sustainable starting point for improving guideline concordance. So your concerns regarding the antimicrobial dose, say for example the guidelines recommend 2 grams of an antibiotic and what's been prescribed is 1 gram, or the route, say for example your patient's on IV therapy and the guidelines recommend oral therapy, or the frequency, so say for example the guidelines recommend twice daily therapy and your patient's on 3 times a day therapy. This is outside of the scope of data collection for the 5x5 audit. So if you normally act upon this information, if you normally have a discussion with the doctor when you notice that the dose or the route or frequency don't match guidelines, then we would encourage you to continue to do so, but that's not information that's captured in the 5x5 antimicrobial audit. That information can be captured in other antimicrobial stewardship audits like the National Antimicrobial Prescribing Survey or the Quality Use of Medicines Indicators. And in those audits, compliance with guidelines is defined as compliance with all those components, not just the choice of antimicrobial therapy. So you do have an opportunity to use other AMS audits to capture that information. Okay, question 4 asks about a reason for non-concordance. And so what this means is that there's a rationale or a reason for diverging from guideline recommendations in terms of the antibiotics selected. This needs to be provided with enough clarity and precision in the patient's notes or on their medication chart or in their electronic medical record to be understood by another healthcare professional. And the rationale must highlight specific patient factors and or refer to a particular clinical context in terms of why a different medicine has been selected. If the therapy is recommended by a microbiologist or infectious diseases physician, this is a documented reason. Those people have specialised knowledge in infections and what the likely causes are and what bacteria or funguses you might see in your patient population, what those bugs are likely to be sensitive to. So that recommendation is a valid reason for non-concordance. We've got a few examples of what might be an acceptable reason for non-concordance. And so, for example, if a patient's been prescribed a broad-spectrum antibiotic and it says it's suspected Pseudomonas species because the patients have recurrent infections, then that would be a reason for non-concordance being documented. Say a patient's first-line therapy might have been quinolones, but the notes say that quinolones have been avoided due to epilepsy. That's also a reason for non-concordance being documented. However, simply writing that ceftriaxone has been prescribed in this circumstance or that meropenem has been charted as per the previous hospital or as per the emergency department does not really constitute a reason for non-concordance as far as the audit goes. So why are we trying to promote concordance with guidelines in the 5x5 audit? We know that unnecessarily broad-spectrum antibiotics, and by broad-spectrum I mean those that work against a large range of bacteria, increases the risk of antimicrobial resistance through selection pressure, and may increase the risk of other adverse events such as Clostridium difficile infection. So concordance generally promotes use of antimicrobial agents that are less likely to cause antimicrobial resistance, Clostridium difficile infection and other adverse outcomes. More importantly, concordance promotes the use of agents that are the most appropriate for the infection being treated. And generally, if you have locally endorsed guidelines or you're using therapeutic guidelines antibiotics, these have been developed and agreed to by a group of infectious diseases specialists or other people in your facility that have expertise in terms of what antibiotics are most likely to be the most appropriate for your patient population. This is also, concordance with guideline is also included as a recommended indicator in the National Antimicrobial Stewardship Clinical Care Standard. So questions 2 and questions 5 ask prompts for interventions, and they ask you to record whether contact has been made with the doctor or medical team. And by contact we mean verbal and or written communication between the auditor and the doctor or the team of doctors that are currently responsible for the patient. And recording whether or not this intervention occurred is evidence of the prescriber getting feedback at the point of care or around the time of prescribing, and is an action, a powerful action that's resulted from the audit. By making interventions, you get in prescribers to think carefully about why they may or may not be documenting an indication for antimicrobial therapy and why or why not they might be using guidelines or selecting different antibiotics in that circumstance. So what we hope is that these interventions actually in the medium to longer term will result in changes to prescribing behaviour. One of the requirements also for accreditation is that your facility monitors antimicrobial use and takes action to improve antimicrobial prescribing. So having that evidence of an audit with an intervention is useful for meeting the National Safety and Quality Health Service standards.
The host has taken the conference off mute.
Okay, so we might just stop at that point and see if anyone has any questions on what we've been through today. So, and what making an intervention means. If you're not asking a question, you can ask you to put your phone on mute.
Yes, I was just about to say that because it's very loud. There's a lot of background there.
Yep. Are there any questions for us at this point?
No, all seems to be fine, thank you.
Hello?
Yes?
It's Helen Badge here. I just had a query, so I was a few minutes late, but with the patients that were coming out of the scope of the audit,
yes,
and then we have documented to provide intervention if they are out of scope. I'm just a bit confused why they would be out of scope and then we give feedback.
Yeah, so if they're out of scope for the audit, so that means that you don't have a guideline to be able to determine guideline concordance with. So say the patient has a really unusual infection and you can't find a guideline that recommends therapy, then you don't need to make that intervention, because the intervention is essentially have you recommended guideline concordant therapy to the doctor. But if there is no guideline that matches what that patient has, then they're out of scope for the audit. So you just do whatever you would normally do as a nurse or a pharmacist or a doctor in that setting.
So it's not everyone that doesn't have concordant therapy, only if there's a particular infection and there's no guidelines that would support either way whether that was an appropriate antibiotic.
Yeah, then those patients would be out of scope. Okay, but for the patients that have common infections where you do have a guideline, they're the ones that if therapy is non-concordant and there's no documented reason for non-concordance, they're the ones we want you to make a recommendation for.
Okay, great. Thank you.
Thanks. Any other questions at this point?
No.
Okay. Excellent. We might put you all back on mute and we'll move on.
The host has placed the conference on mute.
Okay, hi everyone, it's Kate Callaghan here. I'm going to be running through a modified version of our challenging cases tutorial, which is actually adapted to suit our webinar format as much as we possibly can. Usually we'd expect people to be moving through this tutorial on their own, but what I'm going to do today is take you through some cases that are from that tutorial and describe the likely thought processes and subsequent actions that an auditor might take in the given scenarios. So a few points to consider about the challenging cases tutorial. It has been included in the 5x5 Antimicrobial Audit package as a supplement resource to support auditor education and engagement. It does not represent a complete induction to the audit. So you can't just make any auditors use the tutorial and then consider them trained and ready to go without further education and support. Today we're going to be looking at 4 cases, and for each one the auditor will be able to review limited but relevant information from the notes, the chart, the notes and the electronic medical record in order to make their decisions. They're also able to make a decision to contact the doctor or declare the patient ineligible for the audit. So if you were doing this tutorial properly on your own, you'd need copies of the data collection tool, and it's actually a good idea if you've got one handy to have a copy of that in front of you today as well, just so you can follow the line of questions being answered. You would also need, you should also have a copy of the audit user guide, frequently asked questions, and the CAP cheat sheet. You'd need access to a therapeutic guidelines antibiotic, as these are the guidelines that we're going to refer to when determining guideline concordance or non-concordance. And another point to remember is to try to stick to the actual audit rules and don't be tempted to audit based on your own assessment of what's appropriate and what's not. So this is our first case slide. You've randomly selected an 82-year-old male patient who was admitted this morning, and we have access to their chart notes and electronic medical record down here through these icons. We also have the option to contact the doctor where prompted, or perhaps declare the patient ineligible for the audit. So assessing the patient as being eligible for inclusion in the audit should always be your first step. So we'll just review the key eligibility criteria from the first webinar session. And the first point is current audit for systemic antimicrobial therapy. The second point is antimicrobial therapy has been prescribed empirically and is not a continuation of stable treatment. So remembering that empirical prescribing means that at the time of prescribing, the doctor didn't know the causative organism for that particular infectious condition. And the third point is that it's been fewer than 5 days since the in-hospital identification of the audit, of the indication, Okay, so first let's actually start with that first point of eligibility. We'll have a look at the chart first to see if the patient has current orders for systemic therapy. So we've got here tetrazoline, clexane, pantoprazole, candesartan, some glucosamine, rosuvastatin, paracetamol. So it looks like tetrazoline is the only thing that we've got on the chart there that fulfills that criteria, and it's the only antimicrobial charter for this patient. So we want to make sure that that has been empirically prescribed. So we'll have a quick look at the notes in the electronic medical record to see if we can find some information there. So the electronic medical record isn't showing all that much, so we'll go back and we'll have a look at the notes as well. Okay. So we can see here from this entry, the patient has been admitted from Dr. Jackson's room this morning for cellulitis. We have some exam results here, medical history that tells us a little bit. The patient has had recurrent cellulitis, but nothing in this particular entry is suggesting that the prescriber is aware of a causative organism, and it's certainly been less than 5 days since this indication was identified in hospital, because I've just been admitted this morning. So by my reckoning, I would say yes, this patient is eligible for the audit, and we can commence data collection. So the first question asks if there is a clearly documented indication for therapy, which we see down here. We have severe cellulitis documented in the notes. So we answer yes to question 1, which means that question 2 is actually not applicable, and we go straight on to question 3. And question 3 asks, is the choice of antimicrobial concordant with guidelines? So when we're referring to the therapeutic guidelines, we're looking to see if tetrazoline, because that's what's being charted, is what's recommended for our patient. So when we check the guidelines for severe cellulitis, we find that they recommend flucloxacillin, and tetrazoline is only a recommended option for patients with a non-immediate penicillin hypersensitivity. So the patient doesn't actually have any allergies listed here, so we can have a look at the notes again. And the only point of interest that we might find here is actually that the patient seems to have had deranged liver function tests when they've previously had flucloxacillin. So the way I'm going to choose to answer the question to this patient is that they are not receiving guideline concordant therapy, so that's a no for question 3, but that there is a documented reason for this. And because we've answered yes to question 4, question 5, which is the prompting intervention question, is also not applicable, and the audit is complete for this patient. So this is what it would envisage the data collection form to look like for our patient. We've collected our basic information up the top. We've said yes, there was a clearly documented indication for question 1, and then we mark question 2 as not applicable. The choice of antimicrobial therapy was not concordant with guidelines, but we have said yes to question 4 because there was a documented reason for non-concordance. And then question 5 is not applicable as well. The auditor may choose to record some information in the comments section, and that can help with perhaps feeding back information where indicators may have been missed, or even just to jog their memory when they're talking about audit records later on. And I've just put a little red box down here just to draw people's attention to the fact that the date, data collated, and audit record number parameters down on that part of the data collection tool is something, it's the equivalent of for office use only, so the auditor doesn't need to fill that out. That's something that gets filled out when that data is actually collated into the spreadsheet or any other data filing system that's actually being used. So we'll run through why we thought this case could be considered challenging. When it comes to allergies versus adverse drug reactions, not all adverse drug reactions are actually allergies. So most guidelines provide options for penicillin allergies, which we call immediate or non-immediate penicillin hypersensitivities. And these reactions are quite well characterised. So in this case, flucloxacillin-associated hepatotoxicity, or that liver enzyme derangement that we had a comment on in the notes, is widely considered to be an adverse drug reaction rather than an actual allergy, and as a result we said that the patient's therapy was non-concordant with guidelines, but then there was a documented reason for that. And that leads me on to the next point there. Some of our auditors might be tempted to make a judgment about whether or not a documented reason for non-concordance is, in their opinion, a good enough reason. But what we need you to understand is that the audit focuses on prescribing processes. So we're looking at the steps and behaviour of the prescribers who are actually charting antimicrobial therapy. And if they have documented clinical information which they believe justifies diverging from the guidelines, then this actually counts as a positive result. But of course, if our auditors have serious concerns about that, then they should be discussing that with the medical teams outside the scope of data collection. Okay, so moving on to case study 2. Our next case is a 68-year-old female, and our bed list displays their reasons for admission as chest infection. Again, we'll start by making sure that the patient is actually eligible, so refreshing our memory with the eligibility criteria. We're looking for current orders for systemic antimicrobial therapy. It has to have been empirically prescribed for an acute condition, and it should be less than 5 days since the indication was identified in hospital. So we'll go ahead and have a look at the chart. We've got here ramipril, caltrate, vitamin D, clexane, ceftriaxone, azithromycin, and some salbutamol. So ceftriaxone and azithromycin are our current orders for systemic antimicrobial therapy. And if we have a quick look at some of the other information that's available to us, in the electronic medical record, we have an ED report from 2 days ago when the patient was admitted. So that's going to mean that they should be falling inside that 5-day rule. And we also have a sputum culture, but we can see there that nothing's actually been returned from that because the sample is actually saliva rather than sputum. So we can have a look in the notes as well. And we find an entry from the day after the patient's admission. And scanning through there, we have a bit of observational data in there about the patient, but there's no indication from any of this that the therapy hasn't been prescribed empirically. So we'll go ahead and say this patient is eligible, and we'll start that data collection process. So searching for an indication, we see that the notes say pneumonia up here, referred by GP for pneumonia. But I know that that isn't really specific enough to be matched to a particular guideline, so I'm going to search elsewhere for some more information. And you may have noticed when we first looked at the chart that we actually have an indication data documented there on the chart as CAP, so community-acquired pneumonia, and that counts as a clearly documented indication for question 1, so that's a yes, and question 2, again, is not applicable. And to answer question 3, is the choice of therapy concordant with guidelines? We have to have a look at the CAP guidelines, and we realise that the recommendations are different according to the severity of the pneumonia. The prescriber in this case hasn't explicitly stated severe CAP or moderate CAP, which means that our auditor is going to have to make an assessment based on the information that's available. So if we follow the advice provided in the community-acquired pneumonia cheat sheet, the auditor can use either the Smart Cough or CORB score provided on the back page to assist in making their assessment. In this case, based on what I've read, my general feeling would be that this patient's probably not going to be classified as severe, but I'm going to calculate the CORB score for some extra guidance. And to do that, I'm going to go and have a look at the odds from around the time that antimicrobial therapy was initially prescribed. So the C on the CORB score stands for confusion, and based on the information that we've got here, the patient was oriented. There's no indication there that they were acutely confused in any way. So we don't actually assign a point from that parameter. The O in CORB score stands for oxygen saturation at or below 90%, and we can see here that the patient's oxygen saturation was 88% on room air, so we can allocate a point there. The R stands for respiration rate of 30 or more breaths per minute, and this patient had a respiration rate of 29, so no point there. And the B stands for a blood pressure drop, so we get a point if the systolic blood pressure dropped below 90, or the diastolic blood pressure was below 60. And we can see there that the blood pressure was low, but not too low, so those thresholds haven't actually been reached. So I would be calculating a CORB score of only 1, which is more suggestive of moderate CAP rather than severe CAP, and I would agree with that suggestion based on the other things that I've seen for this patient. So the patient didn't have a penicillin hypersensitivity, and there's no allergies listed. With moderate CAP, we would not be expecting this patient to be receiving ceftriaxone and azithromycin, which is what has been charted, but perhaps one of the other options listed in the table on the back of that CAP cheat sheet. So the answer to question 3 for this patient is no. The choice of therapy is not concordant with guidelines, and from what I've read, there's no documented reason for diverging from the guidelines either, which means question 4 is no as well. And that leads us to question 5. That asks if we have contacted the doctor or medical team responsible for the patient with a view to recommending guideline concordant therapy. And in this situation, I would say I probably would, so I'm going to say yes to that question. And again, this is what our data collection tool would look like for this particular patient. So we said yes, they had a documented indication for antimicrobial therapy because community-acquired pneumonia was documented on the chart. We skipped question 2, that's not applicable. Question 3, we said no, the choice of therapy was not concordant with guidelines. We said no, there wasn't a reason documented for question 4. And I said yes, that we did contact the doctor or medical team with a view to recommending guideline concordant therapy. So with regards to the challenging parts of case study 2, sometimes an auditor is going to have to make a determination of severity, and it's not always easy. Sometimes it is, and we've tried to provide some advice and support where we can, such as using the CAP cheat sheet. But the auditor should always be looking for direct or indirect markers of severity in the notes chart or electronic medical record. The direct markers are going to be obvious. Usually the prescriber might have written moderate CAP or severe CAP or the like, whereas indirect markers will be those clinical parameters that create that overall picture of severity. The guidelines themselves should also usually provide advice to assist in determining severity levels, but if auditors aren't confident with their assessments, they can discuss that reasoning with their audit coordinator, other auditors, or perhaps the doctor and medical team themselves. And the other point that I've got there is don't shy away from making interventions. In this case, it is likely that therapy is already working, and that might be the response that you get from prescribers saying there's no reason to change the therapy. But having that conversation about what is the most appropriate therapy and why is still very valuable, and that process can actually be backed up with targeted education or advice during some feedback sessions. So I might just stop there and see if anyone has any questions about the first 2 cases.
The host has taken the conference off mute.
Hi, Trish from Lakeland. It's not a question about the cases, but what I was wondering is, should we be including patients who have antibiotics prescribed for surgical prophylaxis in the audit?
Yes. So sometimes surgical patients can be difficult for that reason because it's not always explicitly stated surgical prophylaxis as an indication, but people have used the audit successfully in surgical patients, and oftentimes they find that indication of surgical prophylaxis is listed somewhere, perhaps even on the anaesthetics chart. It'll say something like patient receiving antibiotics along those lines. So there's usually enough information to warrant saying that there is an indication for therapy documented somewhere. But does that kind of answer your question?
Yeah, no, that's good. Thank you.
No problem.
I was wondering that a few slides ago it said that where it had the sorry, I'm trying to think about it. It was a few slides ago.
All right.
Where the deranged flu shot's been avoided because of the deranged LFT.
Yes.
If it wasn't mentioned in the same entry, like in the notes, if it was mentioned, say, a couple of days previously that the patient had flu shots before and had deranged LFTs, but then a few days later the doctor's written again that he put the patient on Kepzolin but hasn't mentioned in that entry why, is that still a documented reason? Would you still count that as a documented reason?
Yeah, that's where it becomes a bit tricky. It becomes a bit of a judgment call. If you as an auditor are confident that that prescriber has made that prescribing decision based on a reason that they have documented somewhere. So, for example, if that previous entry where they recognise previous arrangement of the LSDs from flu-pox was written by the same prescriber, and that's probably a good enough reasoning in your head to go, I believe that they were aware of that and that is right, or what has led them to make the decision that they've made. But it is a difficult scenario, and it's really hard for us to construct exact rules around that, so it's probably more of a judgment call.
No worries. Thank you.
Any other questions?
No.
The host has placed the conference on mute.
Okay, so we'll launch into case study 3, and we have another 82-year-old male who has multiple comorbidities, and we'll go and we'll have a look at his chart. So we've got some insulin here, paracetamol, ciprofloxacin, and metronidazole here. So I can already see that the answer to question 1 is going to be yes, because we've got diabetic foot injury listed here as the indication for those antimicrobials. And jumping straight to question 3, because we know question 2 isn't applicable, I look up the guidelines and I find that ciprofloxacin and metronidazole are actually not the recommended therapy in those empirical prescribing guidelines for a diabetic foot injury. So we'll go ahead and we'll have a look at for a reason for non-concordance. Look at that, the notes are missing. We thought that actually mimics life on the wards pretty well, so you can't find these patients' notes and you'll have to see if you can gather information from some other sources. So we might have a look at the electronic medical record, and we can see that we've got a progress note there. And reading through that, so an 82-year-old man was admitted to Royal City Hospital on the 24th. So it was just a diabetic foot injury and a few other things, and they were transferred to another hospital on the 29th, that's our hospital. Looking through there, continued poor healing, had 6 days of augmentin, that was on admission to a different hospital. Antibiotics have recently been changed to Cipro and Flagyl yesterday. So I'm actually reading through this now, and I'm realising that this patient's actually been hospitalised for quite a while, and it's been longer than 5 days since that acute infectious condition was identified in hospital. So I've actually just realised that this patient isn't eligible for the audit after all, and I'm going to have to go back, click that icon, and we've successfully identified that patient's not eligible for the audit because it's been greater than 5 days since the in-hospital identification of an indication for therapy. And we choose to discard any information collected for that patient and move on to our next randomly selected patient. So the reason that case study 3 is a little bit challenging is that we know that once our auditors start getting the hang of the audit, they've got the questions memorised, they start really developing a good rhythm, and they audit at a faster pace. And when that happens, it's easy to fall into a bad habit of collecting your data quickly and forgetting to do that initial eligibility assessment. So make sure that you are including that eligibility assessment as part of your memorised and habitual process of auditing and collecting data for your patients. And the last case there, case study 4, our next randomly selected patient has come to our geriatrics ward overnight. She's a 78-year-old female admitted from her nursing home, and we'll consider that eligibility criteria one more time. current audit is systemic antimicrobial therapy, empirical prescribing for an acute condition, and it has to have been less than 5 days since the indication was identified in hospital. Go ahead and have a look at the chart. Okay, so we've got gentamicin, aspirin, amitriptyline, cranberry, multivitamin, pantoprazole, paracetamol, and also noting a penicillin allergy there with a rash and possible swelling. So the antimicrobial that we'll be looking at is the active audit for gentamicin, which looks like it's been prescribed since the 30th, so just for a couple of days. And we'll have a look at the electronic medical record. And we've got a few things here. So we've got a blood culture that's just pending, so that's not going to tell us anything. But we'll have a look at the triage report. 78-year-old female brought in by ambulance from a nursing home. Got some observations there. Patient drowsy, not rousable, noted penicillin allergy, query sepsis pathway. So this is a typical triage report where it gives us just little tidbits of information to kind of set the picture for this patient. And I'll go ahead and have a look at that urine culture result as well. So it's reporting heavy growth of likely coliform bacteria. So that's actually providing us with some information about the causative organism. But I can actually see here that this was posted on the 31st, and that's been reported the day after the antimicrobial therapy was prescribed. So we can still say that that therapy, that gentamicin on the chart, was prescribed empirically, and we can assess it as empirical therapy. Okay, so after reading through the notes, these look like some notes from the medical team from yesterday. We see that the patient was admitted yesterday from a nursing home. They presented with query sepsis delirium, and this case obviously passes that 5-day rule, and we can declare the patient eligible for the audit. So for question 1, we're looking for a documented indication for therapy, and we can see down here that we've got sepsis likely urinary source. So it has been documented there. So I'd say yes to question 1. Question 2 is inapplicable, and question 3 asks if the choice of therapy is concordant with guidelines. Now, sepsis can be a bit tricky. When it comes to sepsis, there's often guidelines for severe sepsis or septic shock, but then non-severe sepsis cases often are treated according to the regular guidelines for what is the most likely infective cause. So in this case, it would be the guidelines for severe acute pyelonephritis. And luckily, both the possible guidelines for this case, so that's severe sepsis from a urinary source or severe acute pyelonephritis, actually have the same recommendations as antimicrobial therapy. So we'll go back to the chart. We've got gentamicin, but with patients got a penicillin allergy with a reaction that possibly includes swelling. It would generally be safest to treat this patient as if they had an immediate penicillin hypersensitivity, which means that the guidelines actually recommend gentamicin alone as empirical therapy. And gentamicin alone is what this patient is actually receiving, so I'm going to go ahead and say that this therapy is concordant with guidelines. And this is what our last data collection tool looks like. So we've got, yes, there was a clearly documented indication for therapy. Question 2 is not applicable. Yes, there was the antimicrobial therapy. The choice of therapy was concordant with guidelines. And then the next 2 questions are not applicable as well. So why was case study 4 challenging? The first challenge of this case was to recognise that sometimes patients can still be eligible for inclusion in the audit, even if they have a culture result suggesting that that's suggestive of a causative organism, because that information wasn't available at the time of prescribing. It's important to understand, however, that if the auditor recognises that the result should lead to a change in therapy, and the therapy hasn't been changed yet, that they actually discuss that with the doctor outside the scope of the audit. And then the second challenge for this case is the fact that sepsis can be quite a difficult indication to audit, and sometimes the auditor will have to determine for themselves if the prescriber was treating for severe sepsis or just a severe infection that was causing systemic symptoms. So it's not always easy to figure out which guidelines to review, and these ones do involve some judgment calls on behalf of the auditor. But as I said before, in this particular case, it could be argued both ways, but we're fortunate that the recommendations were the same regardless of which guideline we actually looked at.
The host has taken the conference off mute.
Okay, John Ferguson. So should we be evaluating the gentamicin dosage there?
No, we're not looking at dose at all in this particular audit methodology. We're just looking at the choice of agent. If it's within your usual scope of practice, if you're a pharmacist or a doctor or a nurse who would usually query those kind of things, so if you're looking at gentamicin order and within your regular scope of practice you would take into consideration whether or not the dose is appropriate, then you can make an intervention or have a look at that outside the scope of the audit. It shouldn't actually affect whether or not you answer question 3 as yes or no, because the question is just asking if the choice of agent is concordant with the guidelines. Well, what we're hoping is that the audit will make people refer to guidelines maybe a bit more often and be a bit more comfortable with the recommendations in the guidelines. So with time, that's something that we hope that the audit can influence.
Okay.
Any other questions?
No. Hi, this is Lydia Chi here. I've just got a question. Very early on in the presentation, did you say that if the dose, the route, or the frequency is not as per guidelines, to then discard that data?
No, so we're just saying that when you're making that assessment of concordance with guidelines, you're looking at the antimicrobial agents selected. So if the dose is non-concordant but the right antibiotics have been selected, then you still mark it as concordant. But if it's within your usual duty of care to have a discussion with the prescriber about the fact that the dose is different to what's recommended in the guidelines, we would still recommend you do that, but you would still answer question 3 as a yes.
Oh, okay. All right. Thank you.
Any other questions? Okay, if there's no more questions, we'd like to thank you all for joining us today and thank you for your time. I hope you found this session of value. Just to remind you, the next session, which will be the last session, is on making interventions and providing feedback for the 5x5 Antimicrobial Audit, and we'll be sending you the links to that session at the end.